is that the wall of the artery is much thicker, and this is mainly due to the second layer, which is the media. It contains smooth muscle fibers, and it's the one that is needed for the elasticity and the contractility of the artery. This is very important for the function of the artery, which needs to have good contractility despite having high intraluminal pressure. This contractility is not quite needed in veins. That's why we see veins are usually collapsed nearby or adjacent to arteries. The subject of this lecture is arteriosclerosis. The word arteriosclerosis contains two parts. So arterio means we are talking about arteries. Sclerosis, as you should know, means hardening and thickening. So arteriosclerosis is arterial wall thickening and loss of elasticity. There are actually three patterns of arteriosclerosis. They have different clinical and pathological consequences. The first pattern is called arteriolosclerosis, and please pay attention that we have two extra letters here, the L and the O, and they refer to arterioles, the smallest sized arteries. This condition affects very small arteries, the ones that are called arterioles, and it will be discussed in a different lecture. We will say its association with certain conditions like hypertension and diabetes mellitus. The second pattern of arteriosclerosis is called multi-berg medial calcific sclerosis. This condition involves the presence of calcific deposits in muscular arteries. It typically affects people who are older than the age 50, and these lesions, because they contain calcifications, they will be visible on X-rays and other imaging studies. They might also lead to palpable vessels if they involve or affect subcutaneous vessels. This condition, if isolated and not associated with any other pathology or disease in the artery, I mean by that there's no evidence of any problem, any other problem like atherosclerosis, this condition alone or isolated would not cause affection of the vessel lumen, and so it would not be clinically significant. So this condition would be visible on X-rays and other imaging studies, as you can see in those images, and under microscope the calcifications would appear as purple-colored deposits within the wall of the media. So this condition affects the media of the artery. It leads to calcifications there. This process is a degenerative process that might be associated with aging, so that's why it's seen in elderly people. This condition, if isolated, will not lead to abnormality or abnormal reduction in the luminal diameter, and that's why it is not clinically significant. The third and the most important and frequently encountered pattern of arteriosclerosis is called atherosclerosis. And the first part of the word athero is coming from a Greek word that means gruel. So there's a gruel hardening of the wall of the artery. And this is very important and very clinically relevant condition. It's characterized by the presence of intimal lesion that is called an atheroma or atherosclerotic plaque. This condition, because it affects the intima of the artery, it will have significant impact on the luminal diameter of the affected artery, and this leads to the significance of this condition. An atheromatous plaque or an atheroma is a raised intimal lesion that contains lipids, mainly cholesterol and cholesterol esters, and is covered by a firm white fibrous cap. Pathogenesis of atherosclerosis have been extensively studied in literature in the last 3 or 4 decades. It's not fully understood, though, but it's said that two things or two events will happen inside the wall of the blood vessel. These are inflammation and the deposition of cholesterol LDL particles. Which one happens before the other event is not really important now. It's important in this stage to understand inflammatory process inside the endothelial cells of the blood vessel wall that is associated with retained or deposition of low-density lipoprotein particles will have an impact on the formation of atheroma and then the progression of atherosclerosis. So the atheroma or atheromatous plaque, that is the hallmark of atherosclerosis, will have two parts or two components, a fibrous cap and a necrotic center. The fibrous cap will be composed of proteins and certain types of cells, and the necrotic center will contain the cholesterol, the LDL cholesterol crystals, besides foam cells, calcification, and some cell debris. The right picture represents a cross-section through an artery that is affected by atherosclerosis, and the diagram on the left side shows us the components of a well-developed atheromatous plaque. So as you can see, there was a great impact, a significant impact on the luminal diameter of this artery. The remaining part of the lumen, which is the white area here, is very small in comparison with the original diameter with this artery. And this is the major problem and the major importance of atherosclerosis. The needle-shaped whitish areas here inside the atheroma itself represents the necrotic center of the atheroma, which contains the cholesterol crystals. On the diagram, they appear as yellowish needle-shaped structures, while on the actual hematoxylin and eosin stained cross-section of the artery, they appear as whitish needle-like or needle-shaped structures. So to summarize, the formation of an atheromatous plaque requires two events: inflammation and LDL particle deposition in the intima. Endothelial cell injury, or what we call also as activation, can be related to many factors like smoking, hypertension, toxins, some immune reactions, hyperlipidemia. All of these will lead to endothelial cell dysfunction or activation. And this event will lead to a cascade of inflammatory responses inside the wall of the artery, including smooth muscle migration, macrophage activation, and the production of extracellular matrix proteins. The inflammation, besides the presence of LDL particles that are now deposited in the wall of the blood vessel, specifically within the intima, all these will also maintain the inflammatory process within the wall. More and more macrophages and smooth muscle cells will be recruited to the area. The monocytes or macrophages will engulf the lipid, and eventually this will lead to lipid core or lipid debris formation within the atheroma. So the process of atherosclerosis is not something that develops overnight. This condition requires many years in order to have a significant clinical impact on the luminal diameter of the artery. In fact, the pathological lesion of atherosclerosis, which is the atheroma, develops around the third decade of life. And then the clinical complications and sequence of events that develop later in the wall of the artery also will develop later in life, maybe on the fourth or fifth decade of life. The clinical phase of atherosclerosis is usually seen in middle life, and these are related all to progression and possible complications that develop in the wall of the artery. These could include aneurysm formation and rupture, possible rupture of the wall of the artery, occlusion by a superimposed thrombus, and this will lead to complete obstruction of the luminal area of the artery, or critical stenosis, meaning that we develop more and more atherosclerosis and the atheromatous lesion is now increasing in size until we reach very small luminal area that is left to give blood supply. So, what determines which atheroma will have complications? And what determines the rate after which complications will develop? Actually, many factors will play a role in this, one of which the plaque itself will play this role. So, plaques that have a thin fat core and a thick fibrous cap and less amount of inflammation will be relatively stable in comparison to the atheromatous plaque that contains a thick fat core, a thin fibrous cap, and more amount of inflammation. And this atheromatous plaque will be called a vulnerable. The word vulnerable versus stable, we mean by that vulnerable to develop complications and progression to complications of atherosclerosis. There have been extensive research work regarding atherosclerosis, and this research has led to the discovery of certain risk factors that are related to the development as well as the progression of atherosclerosis. The evidence in these papers have led to the classification of risk factors into major risk factors and less certain or less important risk factors. The important or the major risk factors have been further divided into modifiable and non-modifiable risk factors. We mean by modifiable the ones that can be controlled by medications and by lifestyle modifications. And non-modifiable or non-controllable risk factors are the risk factors that cannot be controlled using medications or lifestyle modifications. These include the non-modifiable, non-controllable risk factors include increasing age, male gender, family history, and genetic abnormalities involving the metabolism of lipids. The ones that are major risk factors but are potentially modifiable or controllable include hyperlipidemia, hypertension, cigarette smoking, diabetes, and inflammation. Less certain or less quantified risk factors include obesity, physical inactivity, stress, certain hormonal deficiencies like postmenopausal estrogen deficiency, dietary factors like high carbohydrate intake, and lipoprotein abnormalities. So again, looking at the major non-modifiable risk factors, we will find that increasing age by itself is a considerably significant risk factor. It was found that between the ages 40 and 60, the incidence of myocardial infarction as a complication of atherosclerosis in men increases 5-fold, and the death rates from ischemic heart disease, which is a major complication of atherosclerosis, rises with each decade. The second non-modifiable risk factor, which is gender, it was found that premenopausal women, if they do not have other associated risk factors like hypertension, hyperlipidemia, or diabetes mellitus, these women are relatively protected against atherosclerosis when they are compared with age-matched men. However, following menopause, the incidence of atherosclerosis and related diseases will increase in women. Familial predisposition to atherosclerosis can be very complicated and multifactorial. This could be related to familial clustering of certain risk factors. We mean by that certain families are predisposed to have hypertension, diabetes mellitus, or hyperlipidemia, and all of these are considered to be major risk factors for atherosclerosis. So families with these familial clustering are at higher risk to develop atherosclerosis and atherosclerosis-related diseases than the general population. On the other hand, there are certain well-defined genetic derangements in lipoprotein metabolism. If a family is inheriting a certain well-defined genetic abnormality regarding lipoprotein metabolism, family members will have higher risk to develop atherosclerosis than the general population, even if they do not have other risk factors and they are maintaining a healthy lifestyle. One condition, as an example, is called familial hypercholesterolemia. About 20%
90% of cardiovascular events are said to happen without any identifiable risk factors. These could be related somehow to one of the less quantified or less certain risk factors, like the ones that have been described before in the table.